Hello and welcome, fellow student doctors. Today, we will discuss the cavernous sinus. Learning about its contents is as easy as counting from 3 to 6 and saying sympathetic artery. This is because cranial nerves 3, 4, 5, and 6, along with the internal carotid artery wrapped in sympathetic fibers, all pass through the cavernous sinus to control eye movements, pupillary size, and facial sensations. Say it with me. 3, 4, 5, 6 sympathetic artery. Overall, the cavernous sinus is one of the many dural venous sinuses in the cranium responsible for draining cerebral spinal fluid and blood from the brain. Unique to other dural venous sinuses is that the cavernous sinus drains blood from the face and eyes, an area called the triangle of danger. I am not even kidding. Do not pick your nose or you could literally get a brain abscess from the triangle of danger. With that in mind, let's go ahead and get started. To prepare you for test day, you will be able to 1. Describe the anatomy and function of dural venous sinuses. 2. List the contents of the cavernous sinus. 3. Explain the presentation of cavernous sinus syndromes. And 4. List causes of cavernous sinus syndromes. If you know the anatomy of the cavernous sinus, you can answer any question the boards throw at you. So, let me lay a general overview of this content in your mind by broadly discussing the nerves that pass through it. All the nerves that control eye movement and pupillary size travel through the cavernous sinus. These include cranial nerves 3, 4, and 6 for eye movements, and the autonomic nervous system, ANS, parasympathetic and sympathetic fibers that control the size of the pupil. If any of these structures are damaged, the patient will experience ophthalmoplegia or weak or paralyzed eye movements and a fixed pupil. Also, the nerves passing through the cavernous sinus are responsible for sensation to the upper face and include the V1 and V2 branches of cranial nerve 5. If these are damaged, the patient will experience sensory loss to the upper face and an absent corneal reflex, which relies on the V1 branch for sensing touch to the cornea to produce the blinking response. That's a lot of information that can be simply summarized by counting down from 3 to 6 and saying sympathetic artery. Let me show you with this simplified diagram with the pituitary flanking the medial aspect of the cavernous sinus. Now count with me. 3, 4, 5, 6, and say sympathetic artery. With that in mind, let's apply that phrase to this diagram. Count with me again. 3, 4, 5, 6, and say sympathetic artery. This phrase puts all the contents of the cavernous sinus in order. Importantly, you can see that unlike cranial nerves 3, 4, and 5, which are on the lateral border of the cavernous sinus, cranial nerve 6 sticks, see what I did there? Cranial nerve 6 sticks on the carotid artery in the medial aspect of the cavernous sinus. This anatomy will be critical as we go forward. Also, know that the carotid artery is flanked like a fishnet with sympathetic fibers traveling to the eye to control the pupil. In contrast, cranial nerve 3 carries the parasympathetic fibers traveling to the eye to control the pupil. Overall, the structures highlighted here control eye movements and pupillary control, while these structures control facial sensations. The cavernous sinus is one of the many dural venous sinuses in the cranium responsible for draining cerebral veins and cerebral spinal fluid. Dural venous sinuses are formed by 2 layers of the dura mater. Let me show you by taking a cross-section from the skull. The skull and brain have multiple layers, as you can see. Starting with the skin, it is followed by a thick connective tissue layer called the aponeurosis. Under that is the periosteum, which is the layer that provides nerves and blood supply to the underlying bones of the skull. Once inside the cranium, there are multiple layers of meninges. The outermost and toughest layer is called the dura mater, and it is composed of 2 layers as indicated by the arrows. This is important as the teal arrow represents the periosteal dura mater layer. Peri means around, and osteal refers to bone, so this layer is around the bones of the skull. The purple arrows represent the meningeal layer of the dura mater, as it is in contact with the other meningeal layers, the arachnoid and pia mater, as indicated by the purple arrows. The two layers of the dura mater form the durovenous sinuses, named because they are formed from the dura mater and function as venous channels or sinuses to drain blood from the brain. This image shows some of the key durovenous sinuses we will cover later. Importantly, durovenous sinuses also drain cerebrospinal fluid. Cerebrospinal fluid flows in the arachnoid layer of the meninges, specifically in the subarachnoid space. The oid ending means like, and arachnoid refers to the spider-like appearance of this layer as it has spider web-like extensions. Overall, the cerebrospinal fluid enters into the durovenous sinuses from the arachnoid granulations, which drain directly into them as shown. Lastly, the pia mater is the meningeal layer that adheres tightly to the brain tissue, shown here in green. Now that we know how two layers of the dura mater form the durovenous sinuses, let's continue our discussion by naming some of them, such as the cavernous sinus pictured here. The other most high-yield durovenous sinus is the superior sagittal sinus, which serves as the main location where CSF flows out of the subarachnoid space through the arachnoid granulations and into the durovenous sinuses. If you had trouble remembering what a sagittal plane is, the superior sagittal sinus is named as such because it's in the sagittal plane. You are welcome. As you can see, there are various durovenous sinuses. What is important for you to know is that blood from the cerebral veins, facial and orbital veins, and recycled CSF flow from the durovenous sinuses into the internal jugular vein and back to the heart. Let me give you examples. CSF mainly flows into the durovenous sinus system via the superior sagittal sinus. I said this twice on purpose, friends. It's that high yield. Cerebral veins drain into the system through structures such as the great cerebral vein of Galen. Lastly, facial and orbital veins drain into the durovenous sinus system. This is dangerous because the face is in contact with the outside world filled with microorganisms, hence the triangle of danger outlined on my face here. This drains into the superior and inferior ophthalmic veins to the, you guessed it, cavernous sinus. Friends, does this not terrify you? This is absolutely terrifying that the durovenous sinus system is in contact with the outside world. Not only that, the durovenous sinus system lacks valves. You heard that right. The venous system lacks valves, which makes sense because they are formed from the dura mater, not your traditional venous structures, huh? So, microorganisms can potentially enter the skin at the triangle of danger and then spread easily through all the connections of the durovenous sinuses, since it lacks valves to prevent the backflow of blood. Not shown here are the superior and inferior petrosal sinuses that connect the cavernous sinus to other sinuses pictured, propagating the risk of infectious spread. Ultimately, the durovenous sinuses drain through the sigmoid sinuses that become part of the internal jugular veins after passing through the jugular foramina to flow back to the heart. To finish up our discussion on durovenous sinuses anatomy, I wanted you to see how the dura mater form these sinuses within the skull. Just look at all that connective tissue forming these durovenous sinuses. Amazing, isn't it? In these gross images of the human brain, the sinuses are outlined in blue. Focusing on the cavernous sinus, you could see its relative location. In this view, please appreciate that you have two cavernous sinuses, one on each side of the skull, that are connected to one another. That means if one cavernous sinus becomes infected, that infection can spread to the opposite side. If we take a slice through these cavernous sinuses, then we would see this anatomy in coronal section. In this section, please appreciate the pituitary sitting within the sella turcica of the sphenoid bone, flanked on both sides by the cavernous sinuses. Make sure you take a good look at this orientation, as we will use this image throughout the rest of the talk. We will base our discussion on cavernous sinus syndrome presentations in anatomy. Remember, just count down from 3 to 6 and say sympathetic artery, like this: 3, 4, 5, 6, and say sympathetic artery. Notably, you must know that cranial nerve 3 has parasympathetic fibers traveling along the outside of it to the eye to control pupillary size. With that anatomy in mind, let's cover the ways in which cavernous sinus syndromes, meaning ways that infectious, vascular, mass-induced, inflammatory, and traumatic injuries to the cavernous sinus may present. Features vary as it depends on the extent to which the cavernous sinus is involved. Just look at it. Cranial nerves 3, 4, and 5 are laterally located. In contrast, cranial nerve 6 sticks to the carotid artery, as do sympathetic fibers, within the medial aspect of the cavernous sinus. Now, just imagine a carotid artery aneurysm within the cavernous sinus. What will be affected first? Cranial nerve 6 and the sympathetic fibers that travel along the carotid artery, as the aneurysm would have to grow quite large to reach cranial nerves 3, 4, and 5. Overall, ocular symptoms are present in most patients, as nerves to the eye muscles, cranial nerves 3, 4, and 6, are present laterally and medially within the cavernous sinus, resulting in ophthalmoplegia or weak or paralyzed eye movements that can be painless or painful. If there is an infection within the orbit, this can result in painful eye movements due to swelling, congestion, for example. Patients usually present with visual changes, such as double vision or diplopia. Autonomics to the eye can also be disrupted. Along cranial nerve 3 travels parasympathetic fibers to the eye that normally cause miosis or pupillary constriction. If these are lost, the patient may have a fixed dilated pupil. In contrast, along the internal carotid artery travel sympathetic fibers to the eye that normally cause mydriasis or pupillary dilation. If these are lost, the patient may have a fixed constricted pupil in a Horner syndrome. Think Pam Horner to recall ptosis, anhidrosis, and meiosis, PAM, as features of a Horner syndrome. If cranial nerve 5's V1 or V2 branches are disrupted, the patient can present with altered upper facial sensations. Looking at this diagram, you can see where V1 or the ophthalmic division of cranial nerve 5 and V2 or the maxillary division of cranial nerve 5 provide sensations. Notably, that V1 branch is critical for the corneal reflex, where touching the cornea activates V1 to stimulate the facial nerve or cranial nerve 7 to blink. Without V1, the afferent or sensing limb of the corneal reflex is lost. Patients may also present with congestive symptoms, such as chemosis, which means swelling of the tissues that line the eyelids and conjunctiva. Think red, swollen eyes, proptosis or bulging of the eyes, along with orbital and facial edema from increased pressure coming from within the swollen cavernous sinus. As you can imagine, most patients have a headache from all this pressure within the cranium. Lastly, the patient may have systemic features, such as infectious signs and symptoms, or other cause-based features such as hormone-induced changes from a pituitary tumor, as we will discuss. Ophthalmoplegia is present in most patients with a cavernous sinus syndrome, so let's discuss the eye in a bit more detail. First, you must know that all muscles and movements of the eye are controlled by cranial nerve 3, except 2. The superior oblique is controlled by cranial nerve 4, or the trochlear nerve, so named because the muscle under its control uses the trochlea, as you can see in this image, or a pulley system for downward and inward eye movements, such as you would need if you walked down a flight of stairs or went to read a book, you would need to turn the eyes downward and inward to do these actions. The lateral rectus is controlled by cranial nerve 6 or the abducens nerve, which, as its name suggests, abducts or moves the eye laterally via the lateral rectus. The names really tell you everything you need to know, don't they? Here is a chart with all the eye movements. This is way too complicated for me. I just know that cranial nerve 3 does everything that cranial nerve 4 and cranial nerve 6 do not. One classic ophthalmoplegia to know for test day is this one. This image is labeled patient right and patient left. We ask the patient to look to their right. As you can see, the right eye is stuck and cannot move in that direction. What cranial nerve is affected? Cranial nerve 6, or the abducens nerve, as this patient has an abducens nerve palsy. As the eye cannot move laterally via the lateral rectus, or the eye cannot abduct via the abducens nerve. As you can see in this image, the eyeball is stuck as the patient goes to look to their right. This is super high yield because cranial nerve 6 sticks to the carotid artery within the cavernous sinus. So aneurysms of the carotid artery can press on cranial nerve 6, leading to an abducens nerve palsy, an often tested concept. The sympathetic pathway of pupillary control leads to dilation of the pupil or mydriasis. Sympathetic fibers pass through the cavernous sinus along the internal carotid artery. This pathway is so high yield that I want to make some correlations in your mind. The sympathetic pathway is discussed in more detail in our video on pupillary control. For our purposes, realize that it is a 3-neuron chain. The first neuron originates in the posterior hypothalamus, which serves as the autonomic control center in the brain. The second neuron in this pathway is located in the spinal cord, specifically in a section called the ciliospinal center of Budge. Located at C8 through T2 in the spinal cord, the ciliospinal center of Budge is really the lateral horn neurons in the gray matter of the spinal cord, as you can see here. These lateral horn neurons are preganglionic sympathetic neurons that send projections to the superior cervical ganglia, where they will synapse with postganglionic neurons. From there, the third neuron in this pathway will carry postganglionic sympathetic fibers to control the eyelid, pupil, and sweat glands. These are the fibers found on the internal carotid artery in this diagram. This is why I keep saying sympathetic artery, because the internal carotid artery pictured within the cavernous sinus is flanked like a fishnet with sympathetic fibers around it. In the eyelid, sympathetic activation assists in raising the eyelid via the superior tarsal muscle. In terms of pupillary control, sympathetic activation causes mydriasis, or pupillary dilation, via activation of the radially oriented dilator pupillae muscle in yellow. Sympathetic activation of sweat glands also occurs in the face and forehead. Overall, disruption of the sympathetic pathway at one or more of these points can result in a Horner syndrome, characterized by ptosis, anhidrosis, and meiosis. Here is where a cavernous sinus syndrome would exert its effect. Disruption leads to a loss of sympathetic functions, such as the ability to fully raise the eyelid, resulting in ptosis or a drooping eyelid. Loss of sympathetic innervation to the pupil results in meiosis or pupillary constriction, as parasympathetic pupillary constriction is now relatively unopposed. Lastly, loss of sweat gland sympathetic innervation results in anhidrosis, that is, a lack of sweating. To recall these features of a Horner syndrome, use the mnemonic PAM Horner to recall ptosis, anhidrosis, and meiosis. Moving along to the etiologies of cavernous sinus syndromes, let's group them into categories. The infectious category includes bacterial causes such as staph and strep, and fungal causes such as aspergillosis and mucormycosis. These organisms can cause infections in the danger triangle that can spread via ophthalmic veins to the cavernous sinus to cause septic thromboses or blood clots due to infection within the cavernous sinus. Also, Just look how close the bony sinuses are to the dural venous system, the cavernous sinus. So, sinus infections by these organisms and others can also lead to septic thromboses. Speaking of vascular issues, other non-infectious diseases, such as sickle cell anemia, can cause aseptic thromboses, A meaning without, septic meaning infection, so without infection blood clots to the cavernous sinus. Moreover, with the carotid artery passing through the cavernous sinus, pathologies of that vessel can lead to interesting presentations. Masses of the pituitary can compress the cavernous sinus, as evident by its close proximity. Nervous system masses in cancer, including metastases, can also affect this anatomy. Think about it. The dural venous sinuses are valveless. So, cancer cells can travel through those valveless venous sinuses to spread, perhaps, to the brain and even the cavernous sinus. Inflammatory conditions can also affect the cavernous sinus via caseating granuloma formation, think tuberculosis, and non-caseating granulomas, think sarcoid. Lastly, traumatic insults, such as from a car accident or surgery, can result in damage to the cavernous sinus. Expanding on those etiologies, let's discuss infectious causes of a cavernous sinus syndrome. The anatomy tells the story, as the facial veins drain the face, as well as some tributaries from the sinuses, such as from the maxillary sinuses. These connections facilitate the flow of blood to the orbit via the inferior and superior ophthalmic veins. Just look at all those crossovers within this pathway. Ultimately, these drain into the cavernous sinus. This is terrifying, friends, because infections of the eye, face, or sinuses can potentially spread via these veins to the cavernous sinus and the entire dural venous sinus system. Let me show you the danger triangle again. This correlates to this area of the diagram. The most high-yield infectious causes to know include organisms that cause facial, skin, and sinus infections. So, of the organisms listed, which one is this? Whenever you see gram-positive cocci in clusters, think Staphylococcus aureus, where coccus refers to their circle shape and staphylo refers to their tendency to grow in clusters. Of the organisms listed, which one is shown here? Again, we have gram-positive purple cocci, but now they are in chains. This is Streptococcus pyogenes. Strepto refers to their tendency to grow in chains. Realize that staph and strep are found on the skin, so skin infections can lead to abscesses or deeper infections even within the brain itself due to the connections of the facial vein to the cavernous sinus. Which organism is this one? Aspergillus. I know this because the A in Aspergillus reminds me that this fungus has acute angle branching, meaning less than 45 degrees branching, as shown by the red arrow. Moreover, lines between cells in this image, one is just in front of the arrow, indicates Aspergillus's septi, or separations between its cells. This is in sharp contrast to mucormycosis. Let the M in mucormycosis stand for more branching angle, as this is above the 45-degree branching of Aspergillus. Mucormycosis lacks the numerous septi characteristic of Aspergillus. See how smooth the inside of the hyphae indicated by the red arrow is here? The line you see at the bottom is due to mucormycosis branching to its spores. It is not part of its septi. Mucormycosis does not have septi. That is an Aspergillus feature. The mucor image also shows a person with a black, necrotic appearance to their face, highlighting the invasiveness of mucormycosis into the orbit and sinuses, and potentially the cavernous sinus. All these organisms can find their way into the cavernous sinus and spread deeper into the dural venous sinuses, which are made from two layers of the dura mater. So, this can lead to a spread to the meninges to cause meningitis. The meninges touch the brain surface, the pia mater specifically, so this can lead to brain infections and abscesses. There is another pathway for infectious spread via the internal jugular vein, which leads to the right side of the heart that pumps blood to the lungs. So, this can lead to pulmonary abscesses. Wild, isn't it? That was a really interesting case report to read. All these infectious sites have been documented due to infections in the danger triangle. Vascular etiologies involve the internal carotid artery that runs in the medial border of the cavernous sinus. It can develop an aneurysm that can push on cranial nerve 6, causing a lateral gaze palsy, as well as the sympathetic fibers surrounding the artery itself, causing a Horner syndrome characterized by ptosis, anhidrosis, and meiosis. Remember the mnemonic? Pam Horner, friends, as this syndrome will be on every port exam you take. If that aneurysm ruptures, a carotid cavernous fistula is created, which is a direct connection between the arterial and venous systems of the body, a high-pressure to low-pressure system connection. This is very bad, as the aneurysm rupturing fills the cavernous sinus with blood and puts pressure on all its structures, including back pressure through the ophthalmic veins, which is transmitted to the eye to cause chemosis on the left and dilated veins of the eyelid on the right. There are also thrombosis subtypes. The cavernous sinus is a durovenous sinus, a large collection of veins, so to speak, so infectious agents can cause septic thromboses, and non-infectious conditions can cause aseptic thromboses of the cavernous sinus and include inherited and acquired conditions, with a few high-yield examples being listed. Again, thromboses of the cavernous sinus lead to back pressure in the orbit and present with chemosis and other venous congestive symptoms such as facial and orbital swelling, in addition to all the findings of cranial nerve palsies. In terms of mass etiologies, there are 3 broad categories. First, the cranial nerves of the cavernous sinus are located in the peripheral nervous system, so they are myelinated by Schwann cells. This means that any of them can develop a schwannoma. Since Schwann cells are of neural crest origin, they are positive for S100. Their pathological description is described as being dense, with a biphasic appearance. The first phase is hypercellular, with areas of spindle cells, along with a second phase that is hypocellular with myxoid areas. This is what is meant by a biphasic or two-phase appearing tumor. Next, the pink bracket encloses the meningeal layers that wrap around the cavernous sinus and surrounding structures. This represents the potential for meningioma formation, which arises from arachnoid cells, with the histology being described as spindle cells concentrically arranged in a whorl pattern with some moma bodies, which are laminated calcifications as shown by the blue arrow. Lastly, due to the central position of the pituitary gland within the bony depression of the sphenoid bone called the sella turcica, hence why the sphenoid sinus is labeled, it too can cause compressive injuries to the cavernous sinus. The most common type is a prolactinoma. Also, pituitary tumors usually compress the optic chiasm, which is where cranial nerve 2, the optic nerve, fibers cross from each eye. This results in a visual defect called a bitemporal hemianopsia, or loss of the temporal visual fields of both eyes, as shown in the image at the bottom. To close out etiologies, let's briefly discuss those under the inflammatory subheading. Of note, we will not cover the trauma etiologies in more detail because it's as straightforward as any physical insult to the cavernous sinus. Inflammatory etiologies involve 2 broad categories, based on the granuloma formed. On the left is a non-caseating granuloma outlined by the black arrows. You can see that there are dark purple nuclei throughout the entire granuloma. Compare that to the caseating granuloma on the right, outlined by the blue arrows, where there are areas without purple nuclei that are necrotic or void of cells. This is usually due to Mycobacterium tuberculosis having mycolic acid in its cell walls, leading to a necrotic, cheese-like appearance to the granuloma. It is high yield to know that tuberculosis is acid-fast and stains bright pink, hence the use of this color scheme. In terms of causes of non-caseating granulomas, one word encompasses them all: autoimmune. These are all autoimmune diseases that can form non-caseating granulomas within the cavernous sinus. One high-yield correlation is granulomatosis with polyangiitis, or Wegener syndrome, which causes sinusitis. There is literally a bony sinus pictured in this diagram, so this connection makes perfect anatomical sense. To finish our discussion, I want to clarify that a cavernous sinus syndrome is one form of a cerebral venous thrombosis. When you hear that, please immediately think of any hypercoagulable condition, recent surgery, malignancy, etc., that predisposes a person to blood clots in the venous system. The most common symptom is a headache or change in headache qualities. In terms of definitions, a thrombosis in any dural venous sinus is a subtype of a cerebral venous thrombosis. And a cavernous sinus thrombosis is a subtype of a dural venous thrombosis. The most high-yield thing to know about these distinctions is that the best imaging for any type of cerebral venous thrombosis is a MR venography or CT venography, if MR venography is not available, that looks at filling defects within the cerebral veins and dural venous sinuses. The arrow in this image represents the great cerebral vein of Galen. Alright friends, it's time for a flash quiz. The question reads that a hospitalized 25-year-old patient develops a headache and severe pain in his right orbit and sinuses. His skin is necrotic appearing and a culture is performed with results shown. Imaging reveals extension into the cavernous sinus. Treatment is promptly administered. What condition likely predisposed this patient to developing this infection? A. Graves' disease. B. Hashimoto's thyroiditis. C. Type 1 diabetes. Or D. Type 2 diabetes. The correct answer is C. Type 1 diabetes. This patient has developed an invasive fungal infection due to mucormycosis, evident by the broad angle branching of hyphae without septi. The black necrotic eschars or skin is characteristic, along with sinus involvement that predisposes to spread into the cavernous sinus. This patient is likely hospitalized due to DKA, diabetic ketoacidosis, as a result of his type 1 diabetes. Patients with type 2 diabetes can also develop DKA, but it is much more common in patients with type 1 diabetes as the pathophysiology relates to a deficiency of insulin. Mucormycosis is infamous for infecting patients with DKA because the acidic blood of patients, remember it's called diabetic ketoacidosis, so the acidic blood of patients increases the release of iron from ferritin, which basically feeds mucormycosis and enhances fungal growth. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Use the countdown phrase 3, 4, 5, 6, sympathetic artery to recall the contents of the cavernous sinus. Practice with me. 3, 4, 5, 6, and say sympathetic artery. Do not forget that parasympathetic fibers run on the outside of cranial nerve 3. If you know the anatomy of the cavernous sinus, presentation of syndromes becomes manageable, as cranial nerves 3, 4, and 6 control all eye movements, and the autonomic fibers on cranial nerve 3 and the carotid artery control pupillary size. If injured, ophthalmoplegia and a fixed pupil may occur. If cranial nerve 5's V1 or V2 branches are injured, the patient will lose upper facial sensation along with the afferent or sensing limb of the corneal reflex that is mediated via the V1 branch. Etiologies of cavernous sinus syndromes include infectious, danger triangle sinusitis, vascular, carotid artery aneurysm turning into a fistula, mass, pituitary tumor, inflammatory, granuloma formation, and traumatic causes. Lastly, the imaging modality of choice for any cause of a cerebral venous thrombosis is via MR or CT venography. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there's a great big beautiful tomorrow.